So good morning, everybody. Thank you so much for showing up on a Monday morning. We are very, very, very excited to be here. If you haven't been able to tell already, we're doing things a little bit differently with some new service definitions that we have rolling out in North Carolina. So this is really the first time that the decision has been made to actually come to every MCO, have a day full of meetings and planning sessions, meet with your stakeholders and meet with your MCO team to kick off a new service definition. Partly it's because we really want to do this well. It's a service definition that can have a huge impact in the lives of people, and we want to make sure that this is one that we roll out well and that we give people the tools that they need to do it effectively. And so this is actually only our second MCO visit. We were at ECBH on Friday, so MECLink is number 2. We won't tell anybody else. This is one of my favorites, partly because I don't have to drive, because I live here in Charlotte. And I'm going to say that for Pat, too, because she lives here in Charlotte. But otherwise, because this is our home community, and we are very committed to Mecklenburg County and to making things work in this community. So we're very excited to be here. For those of you who don't know, my name is Shireen Carrico. I have a couple of different roles. Most of you know me as the director of Mecklenburg's Promise, which is a consumer-operated program here in Charlotte that provides a variety of different things from recovery education, and we do training for providers and MCO staff, and we also provide an array of peer supports. I also am the new co-director of the North Carolina Employment First Technical Assistance Center. So that is a mouthful, and I can't believe that I keep remembering to say it that way. We will talk about the Technical Assistance Center, but it basically is going to be providing the training and technical assistance around the state of North Carolina, specifically around supported and customized employment. So we're very excited about that. I'm going to have my colleagues, my partners in crime, introduce themselves as well, and then we want to hear from each of you. So Pat, do you want to go next?
So I'm Pat Kuehl, co-director of the MC Employment First Technical Assistance Center with Shireen. We're very pleased to be here. We have a lot to do together today, and we hope that you will not be shy about asking questions or give us comments that will help us make things more innovative and more productive for our community. I've been involved in support employment for over 30 years.
Hi, everybody. My name is Emery Cohen. I'm with the Division of Mental Health, Developmental Disabilities, and Substance Abuse Services, and I'm in the Best Practices team. I'm from Florida originally. I've been here for about 2 years, working in housing and employment and peer support and recovery and yada yada for some time, but I'm really happy to be here and able to roll out a new service definition and partner with my colleagues here to really bring training to you guys and around the state.
So we have a really good mix today, which is really important because this service definition is going to touch different roles within the MCO. It's obviously going to be a switch for providers, and it's going to be a transition for people that we serve. And every role within MCO is going to touch this new service definition in one way or the other. So it's good that we have that level of mix here during the day. So let me run through quickly what we're looking at for the agenda. We really have 3 primary sections that we're going to be talking about. And the depth of which we talk about it is going to be based on what you feel like your needs are, where you're at this particular point in understanding these 3 primary sections. The first one is going to be an overview of foundations in mental health recovery and psychiatric rehabilitation. We'll talk a little bit about self-determination. The reason why we're going to do that is that really lays the foundation of everything else that is to come. Recovery and psych rehab is the umbrella under which all the evidence-based practices are going to be provided and delivered. The second thing we're going to talk about is the new service definition, and Emery is going to walk you through what that service definition looks like. We will make sure that you have slides available to you and the new service definition available to you as well, so that you have a reference point to go back to. The third section that we're going to talk about is the North Carolina Employment First Technical Assistance Center, how we were set up, what we're going to be doing in this fiscal year, and really hearing from you what you need to move forward as an MCO. What we want to do is walk away with a beginning part of a blueprint for supported employment implementation. This is what we did not want to happen. We didn't want to put out a service definition, develop an implementation plan, and hand it to MCOs and say, this is what you need to do, start contracting with providers and have them do this service. We wanted to make sure that we are doing this very deliberately, very mindfully, and very planfully. And in order to do that, we recognize that every MCO is unique in the way that you're structured, in your community, in your provider array, and so one size is not going to fit all with this new service definition. So we are going to every single MCO to hear from you about your provider network, about the community, and you're going to actually develop your own implementation plan. We will provide you with some guidance, potentially. We're going to ask you some questions toward the end of the day to get you thinking about the types of things you might want to put in your implementation plan, but the plan is really going to be developed from you. And it's really going to be your blueprint of how we're going to start operationalizing this new service in Mecklenburg. The whole morning up until about noon, we will be doing the presentations. Then we're going to break for lunch from 12 to 1. We will come back. We will continue with questions and answers from 1 to 2. And then from 2 to 4, you're going to have it's going to be a combination of providers and stakeholders. Come on in. You're welcome to stay during that process. It's actually good if you can stay because then you get a sense of where your providers are at. And we're going to go through a little bit of what we've gone through in the morning to give them a flavor and really give an opportunity to ask questions and get answers about this new service definition. And then we're going to, from 4 to 5, meet back together as an MCO and finish up any last minute questions that you have and put some finishing touches on your plan. So we have a full day planned for you today. Any questions so far? No? We're pretty good? Okay, so there's some new faces. Something that you may not know is back in, I think it was either 2009 or 2010, Mecklenburg County actually developed an alternative service definition for supported employment. And that service definition looked a lot like this service definition, interestingly. So I'm going to choose to say that Mecklenburg was ahead of the game, that we were the pioneers, if you will, at that time. Now, you say, so whatever happened to that service definition? We did pilot it. We piloted a version of supported employment called individualized placement and supports with a provider here in Mecklenburg. The outcomes were actually very good relative to employment. There were some challenges from the provider perspective on really implementing and embracing the evidence-based practice the way that it was designed to be. That's something for us to be aware of as we go along because we have some lessons learned that I think Emory is going to be pointing out to us as we go along. So that is good because this shouldn't be completely new to our community. I'm going to pull back up our presentation. And I want to ask a question. And this is something that this group should know. No pressure. I won't guilt and shame you, but you should know this. So these new service definitions are really based on this approach or belief philosophy in mental health recovery. So how many people in the room have heard about mental health recovery? Raise your hand. Almost every person. Good. So that means we don't have to go too deep into this. You're already the experts, I think. So let's come up with a really good definition. What do we mean by mental health recovery? Good. So meeting people where they're at in their life, in their process, and assisting them in the way they need assistance. And what are we assisting them to do in a recovery community? To be productive citizens, to live their life. I hear a lot that recovery is about functioning, that we want to help people to function, stabilize, and maintain. And my little representation of that is this, that we have learned over years and years and years of both research as well as anecdotally that people don't want to stabilize and function. People want to thrive. People want to live their lives despite having what we call mental illness or substance use challenges. But part of the issue is that our service delivery system is actually designed around two things. It's designed around illness, and it's designed around stabilization. And so this is my representation. For those of you who don't know, I've been in recovery for 25 years for mental health issues. So I have 6 mental health diagnoses, and I've also been a provider for many years. And so this is a very important part of what I do in my life, my work that I do, because I believe it to the core, because I've lived it. And so this is what I tell people. If my past over here is illness, which that does happen to me, my past, And we have a system that, on the illness side, what do we do with people who are experiencing illness? What type of services and resources do we have? Inpatient, outpatient, hospital, all of those type of things. So we have a system, crisis, a lot of, crisis units, crisis services for people who are not well, who are experiencing illness. And then when I move on to from illness, my present is stabilization and maintenance. And what do we have for stabilization and maintenance for people? Pretty much every service other than the crisis and the acute services are designed around stabilization and maintenance. Now think about where you're at in your life right now. If your goal was to stay exactly where you're at, in 10 years from now, your goal is to be where you're at today. And in 20 years from now, your goal is to still be at where you're at today. What do you have to work toward? That's what our mental health system is designed to do, is keep people stable, which also in the mental health community means to keep people stuck in functioning without thriving. And the problem with that is the only place for me to go then is where? Back. And so I go from stabilization to crisis. Stabilization to crisis. Anybody see that with the folks that you serve? Do you see a cycle happening? Okay, so I get sick, I go in the hospital, they stabilize me with medications, I go into ACT service, I'm stable for a little while, it looks like I can function for a little while, and something happens, and guess what? I'm sick again. And so we keep going here. The part of our system that we're missing is actually the thing beyond functioning, and that's called recovery. It's where you have something to look forward to and to work toward that is not that illness cycle. It's actually the wellness cycle. And so one of the things that we want to do is retool our system to be geared toward wellness and recovery as opposed to stabilization and illness. Well, how do people recover? What are some of the things that we need in order to recover? Something to do. I always say we need to do research because I know there's a correlation between mental illness, Jerry Springer, smoking, and playing bingo. I don't know what that is, but apparently if you have a mental illness, all you can do for the next 20, 30, 40 years of your life is sit at home and do nothing. If that is not enough to make you ill, I don't know what is. And yet we push people into that place all the time because of why? Why do we say to people, that's where you need to go? You need to go from this day program to home. Take your meds, go to group therapy. Stable. We want to keep you safe. We want to protect you because you're stable. And we don't want to put too much stress on you because if we put too much stress on you, guess where you go? You go back to sickness. The problem is if you have absolutely nothing to do with your mind, I say your mind is like your body. If you don't use it, you're going to lose it. And if you have nothing to do with your mind, you're going to go back to sick. And so part of recovery is something meaningful to do. And who's it meaningful to? Based on Alessandra's definition of recovery? It's meaningful to me. And so if you're offering me a psychosocial rehab program and that's not important to me, it's meaningless. It's absolutely meaningless. So part of our role is also understand what's important to people and explore what their options are. That's where supported employment comes in. No longer do we believe that people are unable to work. That is actually false. It is not true. It is debunked, whatever. It is a myth. What else can I say about it? People with mental health issues absolutely, positively can work. Anybody know the national unemployment rate for people with mental health issues? What is it? Take a guess. The national unemployment rate. Let's start here. What is our unemployment rate in general in Mecklenburg County? We're sort of between 9 and 10, lingering there. And that's appalling, right? That is completely unacceptable as a community. So we're at 9 to 10% in the general community. What is the national unemployment rate for people with serious and persistent mental illness? 68, 75, keep going. 97, a little bit lower. You don't get a prize for guessing, so I don't know why I'm doing this. 89%. It is 85%. 85% unemployment rate of people with serious and persistent mental illness. What are all those people doing who are unemployed? They're watching Jerry Springer. Of course they are. They're watching Jerry Springer and getting sicker and sicker and sicker and needing more and more services and going from illness to stable and illness to stable. You know the routine. So out of those 85%, how many people say they want to work? If 85% are unemployed, what is the percentage, again, national average, to say they actually want to work? Good guess. It's 75%. That's a huge gap. One of the barriers that we hear is that people don't want to work. Again, that's a myth. There may be a lot of fear that goes along with it, and maybe I don't know what I want to do. I don't even know how to begin seeing myself as an employee because I've been a consumer, a patient, a client my entire life. Making that switch to an employee requires an entire transition of self-identity, self-esteem, confidence. It requires the ability to risk. Those are some of the things that we want to support people to really start thinking about in their lives. Who am I other than a patient or a client? Because when people take on that identity, what they take on with that identity is that cycle of illness. One of the things that continues to get me is when I see a 17 turning 18-year-old kid, and the first conversation that we're having with them is what? Disability. You're 17, you're going to be 18, we need a safety net, let's get on disability, we need to transition you to adult services. Where is the conversation about what do you want to do when you're grown up? About going back to school, about having a life, about being a homeowner, about being a husband or a wife, about working. If you want a home, that is awesome. Guess what? I work for a home. It is not easy. But that's part of what's required in the regular community. So we have a lot of work to do to reshape that issue around how we see people with mental health issues, as well as how people see themselves. Now, the last thing that I'll talk about is, actually last two things, is the idea of psych rehab. Just as an aside, this is one of my favorite definitions of recovery. Recovery is no longer viewing oneself primarily as a mental patient. It's about reclaiming a positive sense of self. It's about seeing yourself as a cousin, a spouse, a homeowner, an employee, all of those other identities that are not client, patient-based identities. And that's what we want to support people to move toward in their lives. The umbrella under which all the evidence-based practices are under is a division of psychiatry, actually psychology, called psychiatric rehabilitation. So when you think about all the evidence-based practices, including supported employment, family psychoeducation, integrated dual disorder treatment, wellness management and recovery, WRAP, consumer-operated services, peer support, I can go on and on and on and on. Pretty sad that I remember all of those things. But all those evidence-based practices are actually under the umbrella of psychiatric rehabilitation as a professional discipline. Psych rehab is the field of psychology that has yielded the research of what works and what doesn't work for people. So that's what we're talking about. Psych rehab is all geared toward recovery and wellness and redesigning your life and redeveloping your identity. Most people don't know that, and that's why I wanted to make sure that I put that up there. It's based on 8 different dimensions of wellness. So our mental health system used to be geared towards symptoms and mental health and diagnosis and labels. That's what we did with people. You come in because you have a mental health issue, and we work with you on your mental health issue. What we've realized is we need to work with the entire person, because if you don't have a home that you feel safe and comfortable in, will that affect your mental health? Yeah. If you have a pending legal issue, could that affect your mental health? If you don't know where you're going to eat every day, if your physical health is compromised, will that affect your mental health? Of course. If you don't have strong relationships with other people, if you don't have emotional wellness, so all of these things are actually combined. And we've realized that in our system, we need to work with the entire person in all these different areas of wellness, not just on mental health. At Mech Promise, as a matter of fact, we spend fewer time talking about mental health than we spend talking about quality of life. Because mental health, we realize, is one piece of quality of life. But if we keep focusing on that, guess what happens? You know that saying, what you plant and what you water is what's going to grow. If we focus on illness, we grow more illness. If we focus on wellness, it's amazing what people can do in their lives. And so we spend less time talking about mental health and more time talking about what do you want? Where do you see yourselves? Then you need to step up and suit up and show up to your life, because you can't blame a therapist or a care coordinator or a doctor about the situation in your life. You're responsible for your recovery. So we focus on those type of things. The last thing we'll talk about before I'm going to kick it off to the service definition is vocational recovery. Anybody know what is vocational recovery? What does that mean? You can guess, it's okay.
It could be about relearning a skill, learning something new, or building upon it, getting back to where you want to be.
Absolutely.
Or vocation.
Getting back to where you want to be. And for some people that means it's relearning, for some people it means unlearning, and for some people it just means learning, right? Vocation isn't something that typically comes natural to people. We learn on the job. We actually learn more on the job than we do in all of our academics and all of our book learning that we've had in our life. We learn on the job more. So that's part of vocational recovery. What else is vocational recovery about? Oh, that is huge. Say that again. Say it again loudly. Absolutely. That is such a vital component of this. One of the things that I hear a lot when we talk about vocational recovery is about getting a job. This isn't about getting a job. Getting a job is just like one piece of it. If you've ever had a job that you have not liked, I'm going to exclude your current job because everybody loves their current job. So excluding your current job, has anybody ever had a job you didn't like? Raise your hand. Almost everybody. How long did you stay in that job? 3 months. You lasted a pretty long time. Until you got another one. Good answer. You stayed in that job till you got another one. And for some of us, we stayed in the job for a long time and had that slow death thing happening, you know, where you have to get up every morning and get yourself to work at a place you don't really want to work and hope for something better to come along. Well, that's what happens vocationally when we paint people into a box. And the box that we often paint people into with employment is what I call the 4 Fs. The 4 Fs of employment. Anybody know what one F would be? Think of it this way. I'll give you a hint. What is an industry that we typically try to push people? What? Fast food, baby! Absolutely. One of the F's is food service. If you have a mental illness, you can work at McDonald's. I have had people say, my doctor said it's too stressful for me to do X, Y, and Z, so I have to work at McDonald's. Yes. Yes. That was my response. Have you ever been to McDonald's during lunch? Is there anything more stressful than that? But we push people into fast food. If you have a mental illness, you can work at Taco Bell or you can work at McDonald's. I don't know what that is. What's another F? So food is the first one. Think about the vocations, I'll say the jobs that we often see people with mental health pushed into. Did you say florist? Yes. The second F is flowers. It's that gardening, floral, cutting grass. It's that type of vocation. So if you have a mental illness, you're a groundskeeper. You don't want me to be a groundskeeper. I trust me on that, nor do you want me to work in food service. So food, flowers, the third one, filth. Janitorial. So if you have a mental illness, you're good at cleaning. Boy, I really am not your stereotypical client, am I? Because I'm not good at any of those 3 things. Oops. Thank God I stumbled upon this. So food, flowers, filth, and the 4th F, anybody know? Factory work. That's your widgeting. Now, in Mecklenburg counties, remember I told you we were the pioneer because we had the first supported employment based on the real service definition of supported employment, the real one. So we are the champions of it. Well, one of the other things that Mecklenburg County championed is getting rid of sheltered workshops. So sheltered workshops is more that factory work. It's that piecemeal. We'll pay you substandard wage for putting together widgets that actually mean nothing, and you'll do that for the next 20, 30 years, live on poverty, or live in poverty, I should say, and do that type of work. The other one is actual real factories that we push people in. So those are the 4 F's, and that's what we don't want. When we talk about vocational recovery, we talk about finding what feeds your soul, doing what you love to do, because that's when you maintain your work. That's when you want to get up every morning. That's when you want to then find the next level in your career. That's what we're talking about today.
And we're trying not to call it DOJ settlement. We're trying to get away from the fact that, yeah, it is, but, you know, the initiative is really called the Transitions to Community Living. So if you hear that, that's, you know, that's what the DOJ settlement is referring to. So the history of ADA in Olmsted, as you may know, started back up in 2009, that they started looking at states and how they're adapting integration mandates as far as people being integrated in the community versus in shelters or in factories or in facilities. And so North Carolina, Georgia, Florida, Virginia, we all have the same type of settlement. Sorry, not settlement, but like a lawsuit letter. Oregon just recently got a letter on sheltered workshops, which is interesting. So we're starting to look at how that's affecting our ability to have people, you know, give them options to be in the community. So what we responded to in August was a settlement agreement saying, you know, don't sue us. We're going to do this. We're going to implement, you know, X, Y, and Z so that we can comply with what we need to comply with, but not have a full-blown lawsuit, pretty much. So that's when we started looking at facilities, adult care homes and hospitals, and how long people have been in those settings and what we needed to do to have people in the community. So basically we have to make sure that our services have access to community transitions and people living in the community, including supportive housing, and all the services and supports that we do must be evidence-based, recovery-focused, and community-based. So it's critical that we all talk about, and not just mental health. A lot of people say, well, DOJ is only mental health. It's really looking at our services as a whole and making sure they're integrated. And we do talk, at least with supported employment specifically, we're talking cross-disability. This is substance abuse, mental health, and IDD. So think about all your providers also that you help with IDD. And we really need to talk about what shared understanding we have on recovery and self-determination. What things do we have in common regardless of disability? The end goal is to be in the community, be integrated, have the opportunities and the services that anybody else would have. So the guiding principles of the settlement are basically individual choice, services in the least restrictive setting, services built on resiliency and recovery, housing settings that enables individuals with disabilities to interact with others without disabilities, housing settings that don't limit access to community activities, focus on helping people increase their ability to recognize crisis and avoid crisis, and enhancing natural and peer supports to avoid those kinds of crises. So like I said before, the target population of the settlement is people in adult care homes with SPMI, individuals referred to adult care homes, and that is what you guys may have heard about diversion. So also folks in state hospitals that have been there for way too long, individuals living in the community eligible for services like ACT or supported employment. And like I mentioned, supported employment is one of the few that we're implementing cross-disability, and I'll talk more about why later. So this is the budget for this year that ends in July. There was a budget allocation for every single year through 2019, and that funding looks differently. But right now we have $10.3 million through July to develop housing and supports, to enhance services, so new money for the services, to develop in-reach and transition coordinator positions. I'm glad to hear of an in-reach staff here. Diversion and PASR screening, oversight, quality management, developing a new data system, and the independent reviewer that's overseeing our compliance. So we have the Transitions to Community Living Committee that oversees all of the projects we're doing. We meet every other week to talk about where we're at and what we need to keep doing and what barriers we're having. Jessica Keith is our special advisor on ADA. We have the work groups that are working on all of these single activities and have stakeholders involved, and making sure we're communicating with stakeholders as well. Have you guys seen the new website, the DOJ website? Okay, well, when you get the PowerPoint, you'll click on there and you'll go straight to it, okay? So basically, the implementation pieces of the settlement include the development of community living options, which is the housing, as well as the tenancy supports and the rental subsidy program. The community services are ACT support, employment, and peer support, empowering individuals to choose where they live through InReach and transition, and diverting folks from congregate housing. So before people even get into the adult care homes, the TYSR screening is going to help identify who they are so we can help divert them. So InReach positions are functions of the MCO. So we have an InReach person here. Do we have a transition coordinator? All you? Okay, so these are folks that provide the ongoing engagement and outreach and education on where you're at and what you can do. You know, this is what the options are for you in the community. This is what we have. Have you thought about moving? Have you thought about housing, et cetera? It's mandated that by December, all individuals providing InReach be North Carolina certified peer support specialists. Transition planning also leads a transition team where the transition coordinator meets with the team and discusses the 90-day window where people need to transition. So once the person says to the InReach person, I want to move, there's 90 days from that point that the person needs to find an apartment and get all that going. So with supportive housing, since now you're familiar with how that works, we do have to provide at least 100 slots by July. That's a lot, but statewide. So those slots also include the rental subsidy, one-time transition supports, and tenancy support services. We've established a tenant-based rental assistance. I always forget that, but it's TBRA. That basically works like a Section 8 housing voucher where you pay a percentage of your income, like 30% typically. Was that the same for this person? Was it 30? Yes, 30. Okay. And NC Housing Search is the website that you can also look for housing if you don't know any others available. So Transition Year Support Resources, another acronym, I don't know how to say that one, TYSR, basically is startup funds to help the person pay for things like deposits and furnishing and appliances. So $2,000 the person will have to pay for those kinds of move-in things that they would need. This is the data system that we're developing. It's going to be tracking all the personal outcomes throughout the settlement. So it's housing, it's services, it's where the person came from, where they went, and all that. And then we have an independent reviewer making sure we're compliant. And she visits us probably every other week and has a call with us very regularly. And I will skip over some of these things, but you will later get it, and if you read it through, and let me, if you have questions. So the community mental health services, this is my baby, and I'm overseeing the 4 work groups. We have ACT, support and employment, peer support, and tenancy support. One of the things I should mention about tenancy support is that comes along with the housing slot. So that's not a service that you guys are developing. That's a housing. Quadell is the one hiring the tenancy support staff, so anybody that has a housing slot is going to have a tenancy support staff to visit them. I think I get into that a little later, but I thought I would mention that. We also want to acknowledge that there's other services available to people that are not just these 4. Okay, this is not the only services that we want to promote, but these are the 4 that we have to enhance right now based on the settlement. So they said, you guys really need to fix ACT, you need to fix support employment, you have to enhance peer support, and that's why we're focusing on these. We will be looking at CST and PSR and some of the other services in the array as well to try to move them up to best practice as well. So the implementation activities we've done with the services, we've had the work groups that have looked at what's happening, what we need to improve and all that for all of the services. We are working on service definitions across the board and developing training and technical assistance to help really develop this in the community. And also the model fidelity reviews and program evaluation that I'll talk about later. So ACT, just to quickly go over some of the services. With ACT, we have to make sure that by July, we have at least 33 teams that serve 3,000 or so individuals that meet fidelity. This is statewide, of course. So right now, what we've worked on a new definition, on a new rate revision. We've done training on TMACT. Was anybody there at that training? Okay, good. So we did that. We are also developing a tiered certification process for teams. So we're collecting a baseline data on of teams and how they meet fidelity for this year. So from now through July, we'll have a score of all the teams in the state and how they measure. And then TMACT is going to really kick off in July. So we'll have a baseline, and then we'll have an ongoing number to know how teams are meeting fidelity. It's like a 1 to 5 scale. You either get a 2, a 4, 2.5, 3.5, and we'll help you get better, as they need to. So we have a new technical assistance center through the UNC Center for Excellence. That just started on Friday. And so they're going to start working on helping us do the evaluations for the teams. So you guys are probably familiar with ACT, so I won't go over that too much. Well, one thing I would say is that all ACT teams now will need to have a voc specialist in the team. That's important as we talk about support employment. They shouldn't have to go outside of the team to get support employment services, not through VR or not through this definition that we'll talk about later today. So keep that in mind. We have all sizes of teams around the state. We did an inventory, and we have about 100, probably 95 to 100 teams in the state. That's a lot. 50% of them are very small teams. So as we measure fidelity, we have to kind of see, are they meeting fidelity, being so small? Are they really doing ACT? So that's going to be interesting. Tenancy support. Every individual with a housing slot will receive tenancy support services, like I mentioned before, and Quadel is the one hiring them. We also added in the job description for Quadel that they incentivize hiring peer support specialists to do this function. And we want to make sure that as they hire, they're still in the process of hiring their first person, so that hasn't even started yet. But we want to make sure that we are offering them training. We're looking at new training through HUD on tenancy support services and supportive housing, and how they can interact with behavioral health providers, because they're going to be over here with Quadel and the housing, and then the providers are going to be over there. So we want to make sure that they're talking, and that the people that they have in common, they're all meeting together at some point, and how to develop that process. And the fidelity scale is going to describe exactly what that person's function is. So the TMACT says, voc specialist does yada, 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 and it's very specific on how much time they should spend doing employment. So thank you. So peer support services, the other definition. We've developed a new definition on peer support. Right now, Medicaid is looking at our draft, but we have a draft. We want to start rolling that out in the next couple months. We've added a lot of evidence-based language to it. There's a consumer operated services manual through SAMHSA that has peer support as an evidence-based practice. And so we've added a lot of information on how that should be done in the community. And peer support is implemented internationally for all disability groups. So we want to really look at that and how that can be expanded. And you guys know peer specialists are people living in recovery from mental health or substance use issues. And we got a lot of questions about this on Friday, so I added a few slides about this. Peer support specialist certification. Are you guys familiar with how that works right now? Okay, so we have the 40 hours, a person gets additional 20 hours, a person demonstrates a year in recovery. They have 2 references, a $15 application fee, and they can become a peer specialist. We have the website as an initiative through UNC. We fund UNC to develop this certification program. And we're also looking at building capacity and training for IDD self-advocates. There's a lot of movement nationally for the IDD population to also do peer support. They do it already. They just don't have a formal certification process or training. So we may develop one for North Carolina. And so what we're doing is expanding peer support. We have a new service definition that will be a B3 service definition and will also be state funded. And we're revising at the same time, the core training elements for that 40-hour course that peers take to become a peer specialist. And we're revising that. We're developing a trainer protocol. So we can know who's training and how the quality of the training is, what peer specialists are getting out of the training, etc. We're also assessing new trainings that we may need. So all the trainers currently there are still doing their thing. When we develop the new protocol, they will all have to reapply. And they either meet the new criteria or they don't. And we have right now over 100 trainers. And it's really hard to tell what they're training and how. So we've left it a lot up to the people doing it to quality, but it's hard, you know how that is. So we really want to develop a standard that we'll do some evaluation and some ongoing technical assistance and training for the trainers themselves to do the training right. Yeah. So some of the other new trainings that, as you've heard me talk, a lot of different functions are going to be provided by peer specialists. So we have in the new service that you'll hear about later, we have employment peer mentors as a specialty area for peers. We have in-reach specialists that can be peer specialists. ACT teams all have a peer specialist in the ACT team. Tenancy support services can be provided by peers and the peer support service itself. So these are a lot of special areas that need training. So peer specialists doing in-reach, what does that look like? What kinds of skills do you need to have to be a good in-reach specialist? So we're going to look at all these things. This is the new map. We've updated the website through UNC and how, I know it's kind of tiny, but you guys will get it later. But this is the spread. Right now, Mecklenburg has 65 certified peer support specialists. So this is kind of how peers spread in the demographics area. We have 394 with high school diplomas, 62 with associates, 183 with bachelors, 14 PhDs. We have 69 veterans. We're really trying to promote this also for vets, as the VA is now hiring a lot of peer support specialists within their program. So that's a really new area. Okay, so support employment. Any questions on DOJ so far? Okay. So some of the initiatives, I thought it was important to mention some of the things as a state that have been happening to promote employment and employment first. You guys are familiar with employment first? Okay. So we have the Business Leadership Network that actually started here in Mecklenburg. So you guys should know about them. And they've started as a business-to-business network hiring to promote the hiring of people with disabilities. Just quickly, we also have an Employment First Steering Committee at the state level that a lot of folks, even from Mecklenburg, are participating in that and trying to promote Employment First as a state initiative. And I'll talk about what that means. We have employment language in the new contract. In the new LME MCO contract, we've added a section on employment and how MCOs should be promoting employment and looking at their services array. We have an Employment First position paper that's been a cross-disability effort endorsed by over 50 organizations. The SELN, you guys may have heard me talk about that before. It's the State Employment Leadership Network, and it's a national network of states that are all looking to increase employment outcomes within their state. So we're one of the 30 or so states that are involved with that. We have also joined the DPI, Department of Public Instruction State Transition Team, looking at how folks in the school system are transitioning to either post-secondary education or employment. Think about that also when I talk about the service definition and how that can also be used to engage students in the school coming out. Instead of going to workshops, they can also be provided support employment programs and post-secondary education. So think about that. We also have an Employment First State Leadership Mentor Program community of practice with the Department of Labor. We're participating in webinars and calls with them to try to understand what's happening nationally and what some of the trends are so we can be in line with those initiatives. Then in August, we got the settlement. So we said, great, now we can enhance support employment services and get funding to do it. We have also done a lot of efforts in success stories and collecting stories from providers which I think is very important to bring a face to employment and employment services. And the success stories are really helpful in thinking about how to expand that in your community as well. We have a new MOU signed between VR and our division. And I think VR may not be here today, but we're really looking at what things we have in common between VR and our state definition. So you'll probably have questions on that as we go through. So think about that. We have an employment webpage also through our division. We were trained through Dartmouth in the new IPS model. So Shireen and I and some other folks, we went to Dartmouth College to get the training from the masters on that. So we could come back and train you guys specifically on that model and how that works. And then the latest is that we have the North Carolina Employment First Technical Assistance Center, funded through the DOJ settlement to help really engage in training and technical assistance for providers and MCOs. So this is what I was mentioning, the SELN. A lot of states coming together to talk about employment outcomes. Employment first. So employment first is like a philosophy, it's a shift, it's kind of how we talk about recovery-oriented system of care. It's really shifting that thought about employment and knowing that employment should be the expectation for people with disabilities, not the exception. That we should expect people to look for work and think about work from the start. And that employment should also be an outcome in all of the services that we provide, not just in supported employment services, but people in ACT teams, are they getting employment? People in PSRs, are they getting employment? And the opportunities to engage in employment. So really thinking about that as a broad-based approach. 19 states already have an employment first policy. And what that means is that the legislation or the governor, somebody signed a proclamation and said, we're going to do this to promote employment, et cetera, how we're going to do it. And so 19 states have that. 6 policies of those are cross-disability, and 14 other states have employment first efforts, including ourselves, looking towards how we can expand that as a statewide initiative. This is our statement. Employment in the general workforce is the first and preferred outcome for citizens with disabilities, regardless of level of disabilities, in a job of their choosing, with supports and accommodations provided as necessary to achieve and maintain employment. So again, thinking about everyone should have an opportunity for employment. Disability is not a factor. We can provide supports and accommodation as needed, and that shouldn't be a barrier for people to obtain employment. So how does employment fit with the ADA and the Olmstead mandate? So going back to why DOJ came to visit and what things have happened, ADA and Olmstead looks at the most integrated settings. Are people provided services in the most integrated settings? This is a setting that enables individuals with disabilities to interact with non-disabled persons to the fullest extent possible. So we know that what is not best practice are sheltered workshops, employment in segregated settings, group employment models, and sub-minimum wages. We'll talk about the group employment one as well, because that will be changing. So the new model that we've developed is based on the fact that by July, we have to offer at least 100 individuals with mental health and substance abuse services and supported employment, and that is statewide. We have already a lot of people receiving support employment and long-term supports through our definition, the one that's currently available right now. So we just need to make sure that they will meet the new standards of the new definition as that goes live within the next week or two, probably. So what this new definition does, it really aims to capitalize on the person's motivations and strengths. So if somebody says, I want to work, they're not waiting 6 months to see you to start talking about work. They start working on working immediately. And new research states that pre-vocational training is not a predictor of successful job retention or higher wages. So there's a lot of research being done on pre-vocational programs. What we focus on is on-the-job training versus pre-vocational training. A lot of people would think that you would train the person and then place the person. We're looking at it differently based on the research. So this new definition also is accessible to all disabilities, IDD, substance abuse, and mental health, including autism and those with TBI, traumatic brain injuries. This is a team approach of employment support professionals that includes new positions of employment peer mentors or peer specialists or self-advocates working to help the people look for work or think about work, and also engage people in other services to think about work. It also enhances the staff level professionalization through training and credentialing. We'll talk about that in a second. And it looks at the provider's emphasis as for employment first outcomes as a whole. So a lot of times people say, is this IPS? It's not just IPS. What we've done is that we've borrowed the IPS principles of the evidence-based model and added on approaches like customized employment and self-employment and business-led internships to really provide a holistic type of approach for people that's individualized based on their needs. So you've heard a little bit about IPS. That's the evidence-based model for people with SPMI. In other states, it's also been used for people with IDD. But the idea is that these services are individualized, and also providers, when they're trained in a lot of approaches, they're better equipped to offer these services to a lot more people and better educated to do that. Our consultants, our national SELN consultants, are also developing a crosswalk between IPS for the IDD population, so providers can know what the similarities and differences are. So when we looked at that, we said, so what do we have right now in the state, and what do we need to change? We did already have a support employment and long-term support definition. A lot of people didn't know about it. But it was underutilized and it was poorly funded for mental health and substance abuse. Some MCOs were funding it through other funding streams. They were adding either block grant dollars or taking it from other services and putting in there. It wasn't mandated. North Carolina, we already had providers offering the services to the population, but a lot of them weren't being funded for it. So when we met in September as a work group to develop the DOJ definition, we realized it's better to use the existing system, just develop and enhance the best practices within it, make sure people are meeting the new requirements. And now it's going to be a required service, so there will be new funding, and the service must be provided to all eligible individuals with mental health and substance abuse as long as they meet the criteria and they want to work. It will also be added to a B3, Medicaid B3, possibly by January. And it's already been added to the state plan amendment for Medicaid. So that's the language about support employment offered to mental health and substance abuse is already in there. So now we'll develop the new service definition to go to Medicaid. We already have the IDD language in there through innovations. So now all disabilities will have access to the Medicaid support employment. One of the things we realized is that to make an evidence-based practice successful, we have to implement technical assistance training and fidelity measurements. Otherwise, it's not an evidence-based practice. It won't work if you don't do those pieces. So through the effective innovations, you add on a really good implementation, you're going to get positive outcomes. That's what implementation scientists tell us. So we had to develop a process. So the same thing with ACT and how we're developing that is really having a process to do fidelity reviews and program evaluation that's clinical, beyond program monitoring and those kinds of things, but something clinical that will help providers improve their services. Developing and collecting data and improving the communications and overseeing this through our Employment First Steering Committee as well. So our Technical Assistance Center, as I mentioned, Pat will talk a little bit about that later, about exactly what some of the things we'll offer you. But one of the first steps was to visit all the MCOs. You guys are the second one, so congrats. And I think it's been so helpful, I think, for you guys and for ourselves, because we get to hear what's really happening on the ground, and we get to tailor what we offer to you guys and what your needs are. Okay, the new definition. You ready? And I know you guys don't have the copies of it. I did put up here page numbers, so I'm glad I did that yesterday. So as we go along, if you write stuff, you'll later get the copy, and then you can reference it, and then you'll ask me more questions later. So what we decided to do, the first thing was, we had two separate definitions. We had supported employment over here, we had long-term supports over here. Like, why? Why is this separate? it's really one service. You have the first piece and then the follow-along. So clinically, it's supposed to be a seamless and complementary service, not a separate one. So the follow-along supports, or what we call here in North Carolina long-term vocational supports, are part of all the support employment models. Every state uses a different term, but basically follow-along supports is what's often used. When it's seen as a separate service, people are often denied because they're like, why do you need this part of it? You already got this part. So that gets very confusing for staff. And also there's a lack of funding because people put the pot of money over here and not over there. And how is that working? So research says that most individuals should receive support employment, long-term supports for a period of time as long as the person needs it, to retain the job and the skills to be successful. And this also doesn't exclude individuals coming out of VR from the support employment first part, and we'll talk about that later. So people from VR coming out and needing long-term support can also get that through this service definition. Some of the core values of this service specifically, I added this section on competitive employment. We got a question about that. Competitive employment is defined as jobs that pay at least minimum wage that anybody can apply for and are not set aside for persons with disabilities. This may include seasonal or temporary jobs. This is what this service definition is focusing on. We're not talking about jobs set aside for people, special jobs for people, that kind of thing. We're talking about any job that you and I can apply for. Those are competitive jobs. We're also talking about integrated community employment in the community with everybody else. Jobs that promote self-determination and recovery, that they reduce stigma by being with other people in the community, competitive wages on an employer payroll or a consumer-owned business or microenterprise, and the development of personal supports and networks. So working with VR, you see the little page numbers there? That's referencing the definition you don't have. So on page 2, you'll see information on the collaboration with VR. This is where it gets a little hairy, and we have to still develop some of that process. We're in the middle of developing a crosswalk between VR and this, so people can understand the differences. But right now, our goal is that people have the informed choice of whether to receive support employment through DVR or through DMH, our division and state funds. It has to do with informed choice because people need to know what VR offers that this one does not, and what this offers that that one does not. So VR will offer things like going back to school and getting a certificate program that this will not pay for. But this will get you working on job very quickly, as sometimes VR takes a little bit of time. So we really have to be clear about what that person's needs are and their immediate needs. And if their goal is, I just really want to get ready for work, then VR will be a better choice for that person. So we need to think about that. So we're going to do a crosswalk. MCOs often are requesting a letter of ineligibility from VR to open the person either through innovations or through this service. That doesn't need to happen. We're developing at the same time with our Medicaid office a guideline about what some of that documentation could be, because that's happening a lot with innovation. So I just wanted to mention that because we're going to come up with some guidance on how that could be handled. A lot of times people are requesting this letter from VR and they're waiting a month or 2 months before they get the service. That's really a barrier to people when they're engaging in employment and really want a job. So the definition is broken up into 2 phases. We have phase 1, intensive supported employment, and phase 2 is the long-term supports. And so phase 1 includes everything from developing an employment plan. What do you want to do? What kinds of things have you thought about? What are your skills? What have you done in the past? Career planning, information gathering, job search, and job development. So going out with the person and helping them look for jobs, the person bringing back leads and ideas, engaging with the employers in the community and the businesses. And then the job site training, if they do need on-site training and that kind of thing. And then at some point, they're transitioning the person to phase 2 long-term supports. So in phase 2, you have that faded on-site job coaching. So at this point, the person is fading out, gauging how they're doing, and the person says, all right, I don't need to see you every day. I don't want to see you every day. Building those skills for coping with work problems, how to handle those issues at work. Coordinating benefits counseling and assistance. One of the things we're really trying to focus on is some benefits counseling training as part of the Technical Assistance Center. We know that one of the biggest barriers for people often is that fear of losing your benefits. So that's one of the critical things that we need to talk about in this service definition. We're also wanting to teach people budgeting skills, financial literacy, and asset development. How to open bank accounts, save money, how does that affect your income, your benefits, etc. And then collaborating with other service providers and supports so that the person's not just in employment services and they only see their employment counselor, but they're also engaging with their other services, their doctor and their nurses and things like that. So table 1 on page 7 and 8 includes the approaches that we're talking about in the service definition. So we're talking about individual placement and support, IPS. That is what you will see when you go to SAMHSA and you look up the Support Employment Toolkit that you may have seen. That's basically IPS. The Dartmouth Psychiatric Research Center developed that through a grant from SAMHSA, and they adopted it as a toolkit. We're also talking about customized employment, and that's been funded and promoted through the Department of Labor, through folks called Griffin and Hammis, and they're the consultants, including self-employment as well. And they have tons of training and toolkits around what that means and how to process with that. We're also looking at business-led internships. These are internships that lead to jobs created by employers. And things like project search, transition to work models. We expect providers to develop their program by utilizing and being trained in all of these approaches as much as possible to be able to better equip providers and the individuals they serve with a very individualized, unique approach to employment. So provider requirements. We expect people to demonstrate some competency in providing employment services, and we also would prefer that providers also be DVR vendors. These are called CRPs, or community rehab programs, that they also have a contract with VR. It's not required, but it's a good idea to do that because we want to help people make an informed choice. So a provider that has a contract with mental health and VR is going to have more options for the person if they need to. The other area here under provider requirements that's very new is around the employment first emphasis, the organizational employment first emphasis. We want providers that have, as an agency focus, they believe in competitive employment, they believe in employment first. Providers shall promote competitive employment in multiple ways by looking at all of their services in their agency. So I could pick Agency X, and Agency X believes that the 5 services that they provide should focus on employment, should promote employment. Employment questions are included at intake. You know, when the person first comes in, they say, where do you want to work? What kind of jobs have you thought about? Starting that conversation early really helps that expectation piece of employment first come to life. And the person says, oh, okay, I'm going to be expected to think about work. You know, it doesn't mean they have to, but it's something that we should always talk about and really engage people. The other thing is around the executive team support. For support employment and competitive employment. This comes directly out of the IPS fidelity scale. And one of the things that we would do is go to meet with the sites when we do some clinical monitoring or clinical guidance and meet with the CEOs. Say, what is your belief on support employment and competitive employment? And have that conversation and really know that the agency has a buy-in and it's supported from the top down. It's not just you guys working over here supporting employment providers, but it's a belief throughout the agency. The other thing we also want is providers that partner with the Business Leadership Network in engaging employers to come to you. You know, employers seeking, providers out and saying, do you have anybody for me? I have 5 job openings or 2 job openings. I'm looking for people. I know you're a great employment provider. Send people to me. So that kind of relationship with the employers, I think, would be really critical for the service. The section on staffing, that's table 2, and it's going to have 3 boxes there. And this is when we talk about the team of staff. These are 3 staff basically. I put 3 to 4 because the 4th one we'll talk about in a second. But basically it has a lead staff, so we're calling them ESPs, Employment Support Professionals. And they have a QP with at least 2 years of support employment experience and 1 year of any type of supervisory experience. We added that on purpose because we want people to have the experience in any kind of job. They could have been a retail boss, they could have been anything, but something that really manages and knows the inner workings of an employment program, of hiring people and that kind of thing, HR, those kinds of understandings. They also provide supervision to staff at least monthly. So these are the supervisors that meet with their team and they talk about things. I added that one. Additional ESP may be either a QP, AP, or paraprofessional. And these staff, with the exception of the employment peer mentor that I'll talk about next, have a range of 20 to 30 people on their caseload. And that just varies because it depends if the person's on the intensive phase 1 or the long-term support phase 2. So if they have more people on long-term support, they could take on some more they need less on this one, or you have to kind of think about that. So providers can also hire additional ESPs as caseloads grow, but the lead ESP must supervise up to 10 staff only. That's based on the IPS model. And so we want a lead that can supervise up to 10 people if they need to, but no more than that because then it would be too difficult to keep track of the caseloads. The staffing continues with the employment peer mentor. So this is 1 FTE. We did that on purpose so we can allow for 1 full-time or 2 part-time, but no more than 2 people can take on this position. And these are folks with a high score GED that have been employed in some capacity in the past. So we want peers that have experience working, that know what it's like to deal with a difficult situation on the job, know what it's like to overcome it, have resiliency, etc., and really have that way to engage people into I've been there, done that, and I'm actually an employee right now, and this is how that works. So that's very critical to this piece. So we have 2 definitions about the role. So if a person is working with mental health and substance abuse individuals, they too must have had experience receiving mental health or substance abuse services. And they're also a certified peer specialist. If the person is working with individuals in the IDD population, they would be a recipient or former recipient of IDD services. So employment peer mentors generally don't have a caseload. So what they do is they're kind of the generalist that kind of helps anyone in the caseload, and they could bill for whichever of the people in the team that the team's serving. They can engage the person as they need to. They can also, one of the things that came up on Friday, they can also go and engage people in sheltered workshops or in ADVP programs. They can go out and engage students, engaging people as they want to transition to the service. I think that's a really critical piece to expanding your services as a provider. So one of the things we allowed, because we know that there may be some capacity issues, especially for the IDD providers that have never hired peer specialists, they're not very familiar with peer support, but we're getting them there, is that they have till December of this year to hire peers in this position. So they could substitute temporarily with an AP, QP, or para in that position. So that's important, I think, for you guys as we develop the service definition. I don't think they should have an issue hiring a self-advocate, but you will hear some providers say, we don't know who to hire, this is new, I don't understand it. There's a little learning curve.